Well, viewers, we will be focusing on today's lectures treatment of prostatic disorders. You see, prostate disorders create big problems, especially in old age in male. And you see, these are your objectives. We will be primarily focusing on the benign prostate hyperplasia and in the prostatic cancer patient. But but let me tell you that the prostate disorders usually contain the prostatitis, and this may be acute bacterial or chronic prostatitis without infection, meaning involving of the bacteria. So, and there may be benign prostate hypertrophy. You see, the treatment may be surgery, like the same option in that case of prostate cancer. You have to excise and decrease the tissue burden. You see, there may be radiation therapy advised in the prostatic cancer, and of course, in the chemotherapy and certain other drugs therapy is advised. So let's go ahead. And in case of prostatitis, you see, the most prevalent microorganisms are that's E. coli and aeruginosa, some anaerobes, and that's why you have to treat these microorganisms. And before arriving the culture sensitivity report, you must be quite vigilant about the spectrum of these antibiotics being used, like quinolones and sulfamethoxazole or sulfamethoxazole trimethoprim combination. So the most problem being posed is the alkalinity of the prostate fluid. So like desaline likes, and mostly drugs are acidic, sometimes that cannot diffuse. So important is that your drug should have a balanced profile. It can easily penetrate into the prostate gland, and like quinolones that can easily go into the prostate gland. Go ahead and let's see what happens. So in case of treatment of prostatitis, like if it's acute bacterial, so you will go ahead for the antibiotic therapy, second and third generation cephalosporins. You can take the support of quinolones like ciprofloxacin, levofloxacin, gemifloxacin, moxie, and moxie is having a good spectrum that is covering the gram-positive microorganism as well. And primarily there may be plants nowadays in the treatment of respiratory tract infection as well, and in the sulfamethoxazole and trimethoprim, you see. So what is the mode of action? These quinolones inhibit the DNA agarase and subsequently decreases the protein synthesis of the susceptible strand of microorganism. But the most adverse effect is the photosensitivity, like with levofloxacin and sometimes chorotoxicity or torsidity points. You see, that is twisting of the QRS complex of an electrocardiogram around the isoelectric point, and then the thyroid function is sometimes affected. Recording combination of sulfonamides and you see the trimethoprim, which is so sulfonamides competes with para-aminobenzoic acid. Why? Because it has structural analog, and this para-aminobenzoic acid helps in the synthesis of purine, and this purine is a base for the synthesis of the protein, DNA, and subsequently the protein. So sulfonamides will inhibit the dihydrofolate synthase enzyme. Dihydrofolic acid will not be formed, and trimethoprim will act at the reductase enzyme, will inhibit that, and the tetrahydrofolic acid will not be formed. So what is this? Is a synergistic effect, and the DNA synthesis will be inhibited of the susceptible strand of the microorganism. But the most adverse effects is the crystalluria, because sulfonamides were initially tried for diuretics purposes. So sulfonamides have inbuilt diuretic activities as well. Now this can be dangerous, especially in children. There may be formation of stone crystals, and crystalluria is there. There may be some hematological disorders like anemia, particularly hemolytic anemia and G6PD deficiency patients. So important message on this slide for you is that how you are going to treat the chronic. Remember, in chronic, the same microorganisms are involved, but in that may go to 3 months. So you will give alpha blockers. Why alpha blockers? Because the capsule size is increased, and the pressure on the urethra, penile urethra, is there, and it cannot permit the mixturation. So you will give alpha blocker, and you will also give for antibiotics activity trimethoprim, ciprofloxacin, or as the case may be. So, in case of chronic prostatitis that's without infection, usually we go for the alpha blockers, and sometimes we go for the empiric therapy if you suspect that there is very blockade is very high, and it can create problem for your patient, subsequent bacteremia or septicemia, and even it can give this wedge pressure that is increased, and the ultrasound report says that kidneys are also being affected. So you can go ahead for an empiric base of uh, give a course of uh, quinolones, or as the case may be. Asymptomatics, no treatment is required. Of course, the patient will not report to you. So in case of the nodular prostate hypertrophy, you see, what you will do, you must understand that how it happens. The capsules, you see, the hormone-driven number of cells and the growth of the prostate gland that is increased. And if that is increased, it is increase in the size, you see, of the prostate gland and the mass. So you have to give drugs that will decrease the size, that will shrink the size of the prostate gland to original normal position. So what is you have to give? You have to give anti-androgens, and of course you can give alpha blockers, so that the urethra being passing through this capsule, there is pressure on that, and that can create problem for your patient. Of course, there may be the second cause is alpha adrenergic tone is increased, and this tone is increased, so you have to reduce the pressure, and that can be through the alpha receptor blocking agent, because alpha receptor blocker are going to constrict the penile urethra and subsequently will obstruct the urination. So therefore, alpha blocker can be drug of choice. But remember, these drugs should be avoided. Why? Because testosterone is steroidal in nature, and all steroids have inbuilt vasoconstrictor property as well. And alpha-adrenergic agonist increase, of course, peripheral resistance will be increased, and that can create problem for you. Anticholinergic drugs also create problem for you, and this lead to dryness of the mouth, and of course, some other problem increasing the adrenergic tone. So now the treatment is, in case of mild to moderate, you see, and usually the non-pharmacological methods are advised, and the non-pharmacological methods includes what? It includes that you will avoid the fluid restriction. It's mostly primarily related to the behavior of the patient, control on the behavior. So when your patient goes to sleep, tell him first go for the voiding of the urine, and if it is not going, so you have to go for the frequent urination. You have to go again and again, and giving a 20 to 30 seconds gap in the first set and the second set. You see, this gap is going to fill is going to help your patient to in emptying of the bladder. You see, so frequent emptying of the bladder is advised. And remember, dear students, what is important? Important is that you have to avoid caffeine and alcohol, because caffeine has an inbuilt diuretic activity, and it increases the hemodynamics. You see how having inbuilt cardiotonic activity, and caffeine will also increase the 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 the, the what you can say sympathomimetic like activity. So it can adrenergic tone is increased, so that's why we usually go ahead and uh, advise the patient to avoid caffeine, and also avoid the drugs. Which drugs? Which exacerbate. So you will avoid this class of drugs because going to exacerbate the patient. So, so, so in case of pharmacological treatment of this class of drug, you have to give alpha blocker. Why alpha blocker? To decrease the urethra, that adrenergic tone, and to let that permit the maturation. So prazosin, tirazosin, you see, and the most adverse effect is the postural hypotension, you see, and usually happen with the first dose. So you have to educate the patient and tell him about the possible adverse effects. Remember, the size is not affected by the alpha blocker. It helps in the maturation. And there may be the third generation alpha blocker as well, like tamsulosin, you see, and this is relatively having a pre-op less incidence of postural hypotension, arrhythmia, and chronic heart diseases. You can use this drug very, with the confidence. So the disadvantage will be in the case of alpha blocker, there may be obstructivism and this irritation may be there. So you may come across with a patient having stone formation, you see, in the urethral or that region as well. So some surgical maneuvers may also be adopted in the treatment of such disorder, because that coincides as well. And remember, they do not decrease the prostate size, alpha blockers, but they do so help in maturation by relaxing the tone of the deep vessel, you see, of this urethral of this urethra. So pharmacological therapy of benign prostate hypertrophy, you can go ahead for the interference with the stimulatory effect of testosterone on the cells of this prostate, and how it is that finasteride and this class of drugs, why? Because they are more quickly, and that lead to 100% suppression of the intraprostatic synthesis of dihydrotestosterone derivatives, you see. So they are going to block the 5,5,5A reductase enzyme, and consequently this enzyme level will be less, and then they can be helpful. So sometimes in severe cases you can combine the alpha blocker and the 5A reductase enzyme inhibitors. Why? Because they will decrease the size as well as they will help in the passing of the urination. These are the signs and symptoms of what you can say the prostate hypertrophic patient. Some summary, as for yourself summary, you can go ahead through that. You will get alpha blockers, and then the second class is 5-alpha reductase inhibitors. You see, it blocks the growth of prostate cells. This is very important. Decrease the size. Relaxation, the tension by alpha blocker mean easy maturation. You see, adrenergic tone is decreased, and the phosphodiesterase inhibitors decreases the diffusal and the prostate and urethral smooth muscle tone, while increasing of the intracellular, increase in the CGMP, cyclic guanyl monophosphate, that has a relaxing effect, and the accommodation for, if this is the bladder, so this is the bladder have these muscles, diffuser muscle, so it is going to relaxation through the stimulation of the cyclic GMP, cyclic guanyl monophosphate. You see level increase, so the accommodation for urine that will be increased. So the size, increasing this particular size of the relaxing these muscles, you will need to accommodate the urine capacity. But that is an indirect. The most frequent use of these class of drugs. These are the side effects. You can see it. Let me proceed. So these are the non-pharmacological methods that we covered in the previous slides. And the most important is that sometimes constipation can aggravate the situation, so you have to treat the constipation as well and advise the regular physical activity. Why go to surgical and chemical archectomy? Surgical archectomy, because the level of this secretion of this androgen and dihydrotestosterone derivatives, if it's increased, you have to remove the testicles, and that's the treatment, archectomy. But there is another terminology, the chemical or medical castration, you see, and that is through the use of large doses of this hormone therapy, and it, to the negative feedback mechanism, it's going to suppress. These are the causes where you go for the hormone therapy. So if the cancer has spread and the level of this hormone is high, and you can prepare the patient for the radiotherapy and surgery, you see, as going to decrease and shrink the size of the prostate gland. So the mode of action, that hormones receptors are there, adrenergic tone is increased. So the treatment strategy is dual. Beside giving alpha blockers, you see, so the androgen receptors, with androgen receptors, these drugs hormone combine and decreasing the DNA activity of the cells. So how it is? This diagram will help you in understanding You know, progesterone is converted into and proglanolone is converted into testosterone and dihydroepiandrosterone, you see. And this can be decreased by blocking the alpha 17 alpha hydroxylase enzyme and drugs that ketoconazole is going to inhibit this process. And remember, there is luteinizing hormone releasing factor from the hypothalamus, or some books say GnRH, and then it goes to the pituitary gland, utilization, and then it goes to the testes, and testosterone level is increased. This is in case of positive feedback mechanism. At the level of prostatic cells, what happens? So these testosterone come and attach with the androgen receptors and increasing the nuclear translocation and increasing the tumor cell growth and gene growth that is increased. So, so what we have to do if we give androgen antagonists or anti-androgen drugs like these glutamate and melutamide and bicalutamide, you see what will happen. This will the androgen receptors, you see that will attach with androgen receptor and the activation will be decreased. You see the translocation will be decreased, and consequently the cell growth will be decreased, and there will be decrease in the prostate cells size as well. So this is another way that I have taken from the Lancet, you see, and the same hypothalamus GnRH, you see, and then it is acting through the luteinization hormone and the testes. So this testosterone is synthesized, and now you can block it. This what you can say this process by taking the GnRH agonist, and you can block this through the corticosteroid as well. You see, corticosteroid releasing factor or corticohormone profit releasing hormone or factor is there, and the ACTH act at the adrenal gland cortex level, secretes the cortisol, and then it secretes the 6 hormones, you see. So you can block it here through the ketoconazole, and from the testosterone comes and attach with ER receptors. Again, ketoconazole can be important, and there is a dutasteride drug, you see, and that goes the hydroderivative of testosterone, epiandrosterone, you see, that comes and attached with AR receptors, and that AR receptors, you see, is going to trigger the protein synthesis here. So these drugs will block the attachment with the DHT, you see, and subsequently the prostate cell nucleus activity is decreased in case of all these sites of action, and you give the anti-androgen drugs, you see. So the most important message on this slide is if you use tumor, and so if you give this GnRH agonist, so it's going to agonist is going to mimic this process, increase this process, and this is called as the tumor flare, especially in the first week or 10 days. So for that you have to combine the luteinizing hormone releasing factor antagonist as well, so that the flare-up phenomena is decreased. These are the drugs available in the market, GnRH agonist. What could be the possible side effects? Then decrease in sexual drive, erectile dysfunction, and of course, shrinkage of the testicle and sometimes the penis as well. Osteoporosis, especially, this can be dangerous, and then the weight gain, of course, depression is there, as we referred to in the previous slides. So in case of prostate cancer, what is the treatment summary? So you have to give the hormonal therapy, androgens, depletion should be there. This is also called as medical castration, and LHRH or GnRH agonist and antagonist is added for what purpose? You can add this to antagonize the tumor flare-up, especially in the first 10 days. And the androgen receptor antagonists, you see, like these drugs can be helpful. Why? Because they goes and attach with androgen receptors and decrease the prostate cell activity. So in a nutshell, sometimes you may advise surgery to reduce the tumor burden and radiation therapy, and low doses of corticosteroid therapy or the anti-androgen therapy to manage the patient with prostate cancer. Uh, the supporting drugs and beside other therapy, as we talked about the ketoconazole in the previous slides. So, what is the message? The message is that anti-androgen therapy is very important. Anti-androgen therapy is very important, and you see the initial flare-up is very important, should be given very importance, and should be managed through the GnRH antagonist or the androgen receptor antagonist could be the best choice. Thank you very much.